remember, everything gets contaminated. Look, 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 and look again. If it's something that you wouldn't want for you or your family member, don't let it happen to your patients. So the World Health Organization talks about 5 moments of hand hygiene. And the other thing is that they also talk about the increase in glove use has unfortunately caused a decrease in hand hygiene in anesthesia providers. So they recommend that gloves should be worn during exposure and removed and then hand sanitized if you put new gloves on. In addition, another opportunity for improvement is the IV port decontamination. They say at least 10 to 15 seconds to fully decontaminate the port. The CDC recommends 30.
Welcome back to the show, future CRNA. I'm so excited for today's episode. We have never talked about it on the show today, which is infection control and how anesthesia providers can cause and prevent surgical site infections. And it's taught by the one and only breath of fresh air, Dr. Cherie Burke. Dr. Cherie Burke is the program director at Loyola University in New Orleans. She started there in 2021 as the director of School of Nursing. She has been practicing clinically as a CRNA. She also has a PhD from Desquinique University in Pittsburgh, received her Doctor of Nursing Practice from La Salle University, and her master's in the science of nursing is from DeSales University in Center Valley, PA, and her CRNA education was obtained by the Frank J. Tornado School of Anesthesia. Dr. Burke received her BSN from Wilkes University. Dr. Burke has been working with New Orleans as the program director for the nurse anesthesia program. However, she has experience as the program director of Rush University's nurse anesthesia program. She has also taught across degrees at St. Joseph College of Maine and Rutgers University nurse anesthesia program. Dr. Burke completed a postdoctoral patient safety fellowship with the Veterans Administration at Philadelphia's VA Hospital and the University of Pennsylvania Simulation Center. Dr. Burke has been an active member of the American Association of Nurse Anesthetists and serves on both the national and state level. Her research interests include patient safety and infection prevention. So, an expert on this topic today. So excited for you to tune in. Let's go ahead and get into today's show.
Hi, welcome. I'm Dr. Cherie Burke. I'm the founding director of the Loyola New Orleans Nurse Anesthesia Program, and I'm here today to talk to you about hospital-acquired infections. I want to talk about anesthesia's role in preventing, mitigating, as well as contributing to hospital-acquired infections. And my topic today is we all have been slimed. Now, what are we going to do about it? Basically, we have to do better. And we'll refer to the AANA infection control standards and guidelines. So the literature is pretty much full of documentation. Infection control is definitely a problem for patient safety. My 2 areas of researchable interest are patient safety, medication safety, and infection control. And we know that hand contamination of anesthesia providers is an important risk factor for intraoperative bacterial infections. The transmission of pathogenic bacterial organisms in the anesthesia work area can be a contributing factor, as well as multiple reservoirs that contribute to intraoperative bacterial transmission. And those are those multiple stopcocks in different injection sites. So we're going to talk a little bit about the literature, the studies, and how we can do better. So what's all the fuss? Let's talk about that. Well, we know that there are about 40 million patients admitted to U.S. hospitals every year. 5 to 10% of those patients will develop a hospital-acquired infection, and 90,000 of these patients will die. And the cost of treating hospital-acquired infections is astronomical. We know that the Center for Disease Control has a whole bunch of information about hospital-acquired infections, and these things have to be reported. And then there was an article in the New England Journal of Medicine in 2018 about the changes in prevalence in hospital-acquired infections. So it's a big problem, and it's a big cost. And if you're the one patient or your family member's the one patient who winds up with a hospital-acquired infection, it can be quite devastating. So Chuck Biddle is a CRNA PhD, used to be the editor of the AANA journal, and he is a brilliant educator. And he says, absence of evidence is not evidence of absence, meaning we don't see patients postoperatively. We encounter patients for a very short limited of time. We see them that day, they're having their surgery, they go home. If they wind up with a hospital-acquired infection, that doesn't always get back to us. The surgeons are caring for them. So we have to be aware that even though we can't see it, doesn't mean it doesn't exist. So transmission of pathogenic bacterial organisms in Workstation, this study looked at 61 operating rooms. They were randomly selected. And what they did is they looked at the sterile IV stopcock where we inject our medication, and 2 sites on the anesthesia machine, the APL valve, which is we call it our pop-off valve, and it's what we regulate to give positive pressure ventilation, and our flow meter controls, which is where we turn on our oxygen and our nitrous oxide and those types of things. And what they looked at was the presence of a positive culture on a previously sterile stopcock set. And the secondary outcome was the number of colonies per surface area sampled on the machine. And they identified the species and the antibiotic susceptibility of these organisms. What they found was quite shocking. As you will see, these are all the organisms that they found, whether it was on the stopcock, the APL valve, or the flow meters. But this is very, very scary. And we need to realize that these things are occurring in our work environment. So retrospectively, a chart review was done post-op day 30, and they revealed a non-significant increase in nosocomial infection rates, but a significant increase in mortality. So those who got an infection had a much higher risk of mortality with their contaminated stopcocks. 5 of 20 patients with contaminated stopcocks developed nosocomial infections, and 5 of 41 patients, 12%, without stopcock contamination developed nosocomial infections. So no big deal. But 2 of 3 patients, 66%, associated with the transmission of a multi-drug resistant organism to the anesthesia work area and or the peripheral intravenous tubing, died in the intensive care unit. So that is really, really scary. So we know there are formal guidelines for hand washings. I mean, Semmelweis was in 1840s, and we are still dealing with this now. Recent studies show that healthcare workers average less than 50% compliance of hand washing guidelines. And in the operating room, there's a little bit more of a challenge to wash your hands. So this is a great article by Ray Roy, who is the chair of Wake Forest University Department of Anesthesia when I worked there. And he wrote this article, "We've all been slimed. Now what are we going to do about it?" And that's where we still need to pick this up a little bit more. We know that 20% of healthcare providers are persistent asymptomatic carriers of Staph aureus and Arneries. 30% of us are intermittent carriers. And because we're constantly shedding our bacteria from our biofilms, our cells, our hair, everything, we as patients and in healthcare providers, we contaminate every operating room we enter. And we should know that our personal slime may be attributing to other people's infections. So what can we do to prevent these surgical site infections? Well, there've been a lot in the literature, and some of these are old articles, but the thing is we haven't made any progress. Hand contamination of anesthesia providers, important risk factors, systematic breakdown in hand washing compliance. And then they instituted an institutional change, which made a big difference. Increased hand washing by anesthesia providers decreased the rates of hospital-acquired infections. So as Dr. Roy says, if we accept that we're all slimed by our personal bacteria, constantly contaminating our environment, and cause some surgical site infections, then we must also accept responsibility for reducing our personal contributions to surgical site infections. And the obvious answer is simple hand washing, but I will show you some other obvious things that are occurring that can be causing this. So you all know these standard precautions. They're on all the time on the ICU doors and things like that, but they're not enough in the operating room. So the AANA adopted expanded and revised infection control guidelines in January of 2022. And if you go to the AANA website or just Google AANA infection control guidelines, and I have the website down there for you. And you'll see the safe injection guidelines for needle and syringe use and infection prevention, control, and anesthesia care. But we'll review some of the highlights. So the AANA scope and standard for anesthesia practice, safe practices for needle and syringe use. They say that CRNAs and other healthcare providers need to take necessary precautions to minimize the effect of infection on themselves and their patients. And we have to act and practice in accordance with our professional standards established by the profession. If you have a patient who develops some unique bacterial infection or viral infection, and they can contribute it to you, and they ask you, did you follow these standards? And you didn't, you're in breach of our practice guidelines. So We follow the CDC's one and only campaign for safe injection practices. These things all came out of the fact of bad things happened. There was a endoscopy center in Las Vegas where nurse anesthetists were providing anesthesia, and they would take a dispensing pin, as we call them, and they would put it in the propofol, and they would draw off many, many syringes from there. Well, one day someone must have gone back with a dirty syringe and drew off there and contaminated, and there were upwards of hundreds of people who were exposed to Hep C. Very, very bad. That was before they even had anything to treat Hep C. And so we are encouraged to consult the position safe practices for needle and syringe uses and follow these standards. So what's going on? Well, preventing the transmission of infectious disease involves many, many considerations and best practices. So the following statements reflect the current safe practice for needle and syringe use by nurse anesthetists or nurse anesthesiologists. Never administer medications from the same syringe to multiple patients, even if the needle is changed. I know that sounds really silly, but honestly, in the late 80s, early 90s, that was done. Never reuse a needle, even on the same patient. Once a needle's been used, and we're not talking about IM, we're talking about IV, inserting it into the IV port. That was before we have needleless. Some places maybe still have the rubber things where you can put a needle in, but we don't have rubber needleless injection ports. So needles are single-use devices. So when we're injecting a dose of medication from a syringe through an intravenous port, the needle may enter the port only once, then it must be discarded. So if you drop 250 mics of fentanyl, 5 cc's, and you give 50 mics, and you still have 40, and you used a needle, you have to change that needle. You can't stick it in the port again. And you should never refill a syringe once it's been used, even for the same patient. Basically, if we had a syringe and it had 50 milligrams, 5 mLs of rocuronium, people would take that syringe, put a clean needle on it, draw up again, and use the same syringe for the entire case. They might use that 3 times. Well, the problem is the internal barrel of that syringe is considered contaminated. It's touching different places on the anesthesia workstation, the anesthesia machine, and it becomes contaminated once it goes through. So you must discard the syringe. And you'll see anesthesia providers who we will use a 50 cc syringe for infusing propofol. We have infusion pumps that are syringe pumps. So they'll put a stopcock right at the hub of the syringe where it connects with the infusion tubing. And what they'll do is they'll drop another 20 or 30 cc's of propofol from a vial. They'll turn the stopcock, shoot it back into that 50 cc syringe. Now the plunger is moving back up and it's contaminated. And we know that propofol has no antimicrobial in it. So we've got even bigger problems there. So this is still a real problem in anesthesia.
Well, hello, future CRNA. I wanted to share another daily dose of inspiration from a highlight from our community. This big shout out goes to Taylor. Congratulations on your CRNA acceptance. Thank you so very much for sharing your story. I was accepted into program. Again, I don't disclose that. I wanted to thank the Academy for all the resources in this community for the support and advice. They specifically asked me about being a member of CRNA School Prep Academy in my interview and asked how I think it benefited me. This was my first year applying and I only applied to 2 schools. I got interviews at both. I believe this program really put me ahead of other candidates and showed my determination and growth. Thank you. Thank you, Taylor. I appreciate those sweet words and your testimonial, as well as your story. It's so inspiring, and I'm so incredibly grateful to have you be a part of our community. Cheers to your future. I'm rooting for you. Let's go ahead and get back into today's show.
And expiration times for medications. First of all, medications should be drawn up as close as possible to the time being administered. So first thing in the morning, you should not drop 5 syringes of succinylcholine, 5 syringes of lidocaine, 5 syringes of Decadron, 5 syringes of Zofran. You drop for that specific patient that you're going to be caring for. And this environment is not always obtainable by anesthesia practitioners in the OR suite to use the hand sanitizers or to do it within 1 hour. But you must be very cognizant of how you're doing it, and you're keeping clean from dirty and your hands are clean when you're doing this. In addition, we must label our preparations with the medication name, concentration, and the time that it was prepared. We in anesthesia are the prescriber, the dispenser, and the administrator. So we've now taken out the nurse who's checking the order. We've taken out the pharmacist who's going to get the medication ready and double check the order. And then you, as the nurse who receives the medication from the pharmacy, check it for the third time. We've just cut out all of those people. So what you'll find is most anesthesia providers will put labels on their syringes, but they won't date, time, and put their name, initials on it. Very, very important that you do that. You'll see them do it with propofol, because propofol, unlike in the ICU, must be discarded in 6 hours of being opened. Even if you're hanging a 1,000 milligram, 100 cc vial, and you're going to use it slowly for intravenous anesthesia during the procedure, if the procedure goes 12 hours and that same vial is hanging, you must take it down after 6 hours. And one of the things that anesthesia providers don't always do is all medications in the perioperative setting are single-use vials, not multi-dose vials. So if you open a vial of labetalol and it's 30 mLs, a bottle of labetalol, and you only draw out 5 cc's, 25 milligrams, you must discard that labetalol at the end of that case for that patient. I have seen people come in. I had an anesthesiologist when I was doing a case, and we were emerging. The patient was hypertensive. I was with a registered nurse anesthesiology resident, and he stuck the rock uronium syringe in the labetalol vial, drew out 5 mLs, and gave it. Now, I said to the resident afterwards, did you see what he did? And they said, yeah, he gave labetalol. I said, did you see what he used to give the labetalol? They said, no. If they would have put that labetalol vial back in the anesthesia cart, we could have contaminated future patients. So these things happen. In addition, the rubber stopper, when you flip off the plastic lid on any medications, should be disinfected with 70% isopropyl alcohol before accessing. Okay, that is not always done in anesthesia. In addition, your stopcock as well as your injection site should be scrubbed with alcohol before injecting. Now, if your patient is coding, you have to give epinephrine, all bets are off. But most times we have the time to swab and scrub those injection sites, and I do, and you should. So despite having this knowledge, we continue to see unacceptable practices in our setting. This was a very, very interesting study done by Kelly Ford back in 2013 when she was a student at Excella School of Nurse Anesthesia in Western Pennsylvania. And she sent out a questionnaire to SRNAs. And this would be a great scholarly project if someone's thinking about a scholarly project to redo this and see if we're doing any better. And these are the questions she asked. Have you ever administered medications from the same syringe to multiple patients? Sadly, 14 of her respondents, 4%, said yes. Have you ever reused a needle on the same patient? 59 or 18%, yes. Have you ever refilled a syringe once it's been used, even for the same patient? This includes the syringe on propofol infusions. All right, 82% said yes. Have you ever reused infusion or IV administration sets on more than one patient? The fact that 2 said yes just really, really concerns me seriously. And have you ever reused a syringe or needle to withdraw medication from a multi-dose vial? 22% yes. Have you ever re-entered a single-use medication vial, ampule, or solution to prepare doses for multiple patients, even if the needle and syringe is clean? 49% yes. Have you ever witnessed a CRNA do any of the prior 6 activities? This is what's really scary. 81% said yes. And have you ever been asked or instructed by a CRNA to do these prior activities? 58% said yes. We have to do better. I want you as providers to be the change we need to see. And even if someone asks you to do something, just say, my faculty member told us that this is against the AANA infection control policies, and we must adhere to all the AANA policies. So I'm just going to do this real quick. That's all you have to say. It's helping to educate them. And per the CDC, we have to cleanse all line ports and stopcocks with alcohol prior to entry, 30 seconds. They did a study and they saw that there was a significant difference between 15 and 30 seconds of scrubbing the hub, but not much difference between 30 and 60. So that's, they came up with 60. When you flip the top off of those vials, you must scrub the rubber stopper. Glass ampules should be cleaned with alcohol before popping the glass ampule. And do not, you will see anesthesia providers do this, draw fluid. They'll stick a syringe into the port on the IV and draw fluid out of it, or from the stopcock and draw tubing up into it to dilute or flush or what have you. Use individually wrapped saline syringes and flushes as dilutants and as flushes. There are good reasons to be doing this. Once you enter those little stoppers on the IV fluid, you are allowing bacteria to get in there. You know, when you get those bags from pharmacy and they've mixed drugs into 250 bag of fluid, they put a little protector over there to keep microbial agents from getting. We get aerosolization in the operating room, blood gets sprayed up, not IV fluid, irrigation fluid, things like that. So very important to remember this. Of course, hand hygiene is most important. You should not wear rings or jewelry to the operating room. I leave my rings at home. Remember that we must use soap and water if our patient has C. diff. And you need to rub your hands for 15 seconds. We have the hand sanitizers on our anesthesia carts. People just aren't using them. So the recommendation by the AANA is to double glove when you're about to intubate and remove the outer glove before you touch your anesthesia bag or your flow meters or your vaporizers. The other nice thing is if you have a second glove on and for some reason you didn't get the intubation into the trachea and it went to the esophagus and you have to open the mouth again, you have another clean glove on. It's much quicker. Then if you did use your second glove, you would take that off before touching anything. And we need to make sure that we keep our contaminated equipment on the anesthesia machine shelf and keep grossly contaminated equipment covered with an impermeable cover and keep all of our clean equipment back on our back cart where we set up. Do not mix clean and dirty. And always monitor your environment and clean up. If you notice something on it, get those. We have the microbial wipes right there, wipe them down. I start every day in the morning with a pair of gloves and microbial wipes, and I clean my anesthesia machine and my anesthesia work setting prior to starting. I know that I'm starting with a clean environment. Then I draw my medications up and I do all those things. Some places the anesthesia techs are very good, other places maybe not so good, or maybe housekeeping, and they don't understand the importance of everything of doing this. So one of the other things I'd like to say is that arterial line insertions should be done with aseptic sterile technique. You're supposed to clean the site, infiltrate with local anesthesia. You need to prep and drape sterilely, use sterile gloves in a sterile field and a sterile catheter. And so very, very important. You will see people do this with just the regular latex gloves. Not a good idea. And then remember, everything gets contaminated. Look, and look again. If it's something that you wouldn't want for you or your family member, don't let it happen to your patients. So the World Health Organization talks about 5 moments of hand hygiene. And the other thing is that they also talk about the increase in glove use has unfortunately caused a decrease in hand hygiene in anesthesia providers. So they recommend that gloves should be worn during exposure and removed and then hand sanitized if you put new gloves on. In addition, another opportunity for improvement is the IV port decontamination. They say at least 10 to 15 seconds to fully decontaminate the port. The CDC recommends 30. And lastly, increased environment cleaning is very, very important to prevent these infections. Mobile phones, we use them for everything, right? We use them as our calculators. We use them to communicate to other providers and things like that. Mobile phone contamination rate of 94.5%, with 37.7% having methicillin-resistant strains. Very scary. 87% of the bacterial load reduction after decontaminating with 70% isopropyl alcohol. Between every case, if you've touched your phone, which we do, you need to decontaminate your phone. In addition, you're putting it right up here by your face. Very, very scary. And there was a small study that I thought was very fascinating, and they looked at adverse effect of noise in the operating room. We play music, there's a lot of talking, things like that. What they found was that the higher the noise level, the higher the risk of surgical site infection. It wasn't the noise that caused the infection, but if the scrub person accidentally hit something with the instrument and then proceeded to pass it, there was more of a breakdown. People were less engaged, less able to hear. And so they don't recommend having a lot of ancillary noise in the operating room. Haven't sold that to too many people, though. It's a very long day if you don't have a little music, but it shouldn't be at decibels that'll make you deaf. So how much are we to blame? I would venture to say we probably are definitely involved in increasing surgical site infections, and there's a lot we can do and to do better. And I know all of you, when you become CRNAs, will remember these things. Do not become complacent. So a little bit about Loyola University of New Orleans, where I'm the founding director of the nurse anesthesia program. We are the second program in the country to offer a CRNA program and a dual CRNA adult general acute care NP program. We currently have 16 first-year students. Of the 16, 11 opted for the dual. It is a 36-month program, whether you're CRNA or a dual student, and you culminate with your DNP. All of our clinical sites are within 3 hours of the greater New Orleans area. Most of them are within an hour. We offer open houses in the fall. Our applications open in Nursing CAS in September 1st, and they close on December 15th. We then select candidates to interview in February, and within a week of the interview, we will let you know if you've been accepted. We are a small program, only 24 students. We don't want to be a mega school. We know that you have a choice where you go. I know that you'll apply to many, many programs. And what I want you to do is I want you to attend many open houses. We offer ours virtually, as well as we offer one in person. But you need to find a place where you feel that's going to be a good fit for you for 36 months. We hope that that will be Loyola. You can opt into the dual program up until the 3rd semester. Once the 3rd semester starts, that's when you start your first adult geriatric acute care NP course and practicum. And if you start out as a dual student and after the first 2 semesters say, I don't want to do this, at any time you can opt out of it. We are what we call an integrated program, meaning that you'll start with us. We have everyone move to New Orleans at the beginning of the program because there's a lot to learn from the upper cohorts. We'll have journal clubs, we'll have bonding and mentoring going on. And all the first semester courses are offered asynchronously online. Those are your DNP courses and your first advanced patho that all APRN students take. The 2nd semester, you start into nurse anesthesia courses, and those courses are in person on campus with the faculty. And you'll continue to have DNP and advanced pharmacotherapeutics and advanced health assessment online asynchronously. So that's how we do it. Every one of our students starts clinical the first semester, their 2nd year. We integrate you into clinical slowly, 2 days a week for the first 2 semesters of the 2nd year, and then full-time for the 3rd semester, the 2nd year, 1st and 2nd semester of the 3rd year. And then we bring you back down and slow you down that last semester, your 6th semester in the program, to get you prepared for your certification exams. So I hope that you found this interesting, and we would love to hear from you. You'll be able to find us in Nursing CAS for applications, and we also are in CRNA School Search. Thank you.
Hey, future CRNA, as always, I appreciate you and your loyalty. Thank you so very much for tuning in this week. I'd love to hear from you, so screenshot this episode and share it to your IG stories with your biggest takeaway. Don't forget to tag me at CRNA School Prep Academy so I can personally thank you. Be sure to head over to CRNASchoolPrepAcademy.com to check out our blog and gather free resources to help you along your CRNA journey. Stay strong, and I'll see you next week.